Recording in progress.
Good evening and welcome to our town hall on COVID and childcare. My name is Jennifer Arnaiz. I'm with the Department of Health and Human Services and oversee childcare support services. I will be your moderator this evening. Before we get started, I want to go over a few housekeeping items. There is simultaneous Spanish interpretation available for tonight's town hall. Please click the globe at the bottom of your screen. It is located in the Zoom control panel. After a brief introduction by our interpreters, Mario and Claudia, you will have access to interpretation of this town hall. Tonight's event is also being live streamed to our county's Facebook page, YouTube channel, and county cable, where it will live after tonight for future viewing. Thank you to those who submitted questions to help develop tonight's agenda. If you did not submit questions, there is a question and answer feature in the Zoom control panel where you can submit. We will also be accepting questions from our live streamed audience on the county's Facebook page. While we may not get to everyone's question, we will follow up with written answers. Tonight, we have allotted approximately an hour for tonight's conversation. I'll be asking each panelist questions on various topics related to the guidance and COVID in general. Our goal for tonight is that we will cover a variety of topics based on the questions submitted and received over the past week. There are 5 specific items that have been requested multiple times. Understanding the differences between isolation and quarantine, review the updated and consolidated guidance for decision-making, understanding testing options, know what is entailed when reporting suspected or positive cases. We will also discuss how the county is supporting the childcare community with acquisition and distribution of supplies. So let's begin tonight's town hall. I would like to introduce each of our panelists who are joining us tonight. Please help me welcome Dr. Raymond Crowell, Director of the Department of Health and Human Services. Dr. Earl Stoddard, Assistant Chief Administrative Officer, Office of County Executive. Dr. James Bridgers, Acting Health Officer and Chief Public Health Services. Ms. Sylvia Kitch, Chief Division of Labor Relations and Public Safety, Office of County Attorney. Mr. Sean O'Donnell, Program Administrator, Public Health Emergency Preparedness and Response. And Ms. Kimberly Townsend, Senior Administrator of Communicable Disease and Epidemiology. I'd like to first welcome Dr. Raymond Crowell to say a few words to our childcare community to set the tone and get us started on tonight's town hall. Dr. Crowell.
Thank you, Jennifer. Thank you for all the work you've done in putting this together, for your team and the work that you and my team in early childcare has done over the last few years. Thanks to the providers for joining us tonight and for all that you've done over the past 2 years and for the work you continue to do to continue serving our childcare needs, the childcare needs of our friends and families. There's been a lot that has gone on in the past month. Boosters have become available, vaccines for young children are on the horizon. Omicron has erupted and disrupted our lives. We've expanded the availability of testing and an emphasis on testing and rapid tests. Guidance has been coming upon guidance fast and furious, and there's news on the channel every day about every little nuance of the virus. We're all tired, and quite frankly, at times a little bit flooded trying to digest everything we hear as consumers of news and information. It generates, understandably, some confusion and some anxiety as we try to figure out what it means for you and your family and your work. Last week, Dr. Bridgers issued updated guidance for Montgomery County, including guidance for school and child care providers across the country. There have been a number of questions and concerns that were raised, so tonight we want to clarify that guidance and take some time to answer those questions. The panel tonight will give you an overview of the guidance Dr. Bridgers issued last week, as well as clarify what went into developing that guidance and why it was put out the way it was. Before I do that, I want to talk a little bit about guidance itself and what that means. Whether it is from the Centers for Disease Control, the Maryland Department of Health, the Maryland State Department of Education, or our County Public Health Office, guidance is just that. It is guidance. It is not a mandate and it's not a health order. It's recommended actions that are provided to protect us all in the face of this virus. You'll see in the news routinely that the Centers for Disease Control issues guidance related to the virus. They've been doing it since the early days of this. Once they issue a guidance, shortly thereafter, typically the Maryland Department of Health will issue a guidance that is built off of what MSD, the CDC, has done, and the State Department of Education will also issue guidance. And then you may typically see our local health office issue some guidance, although sometimes we issue it independent of that flow of information. The CDC issues guidance that is tailored to meet the needs of the entire country, from small counties with 5,000 people to cities with multiples of millions of people, and it's based on what they see at the national level and trends they see across the country, and it is very broad in their recommendations. The Department of Health and MSDE have the job of doing the same thing for the state. And so they're looking across the state in all of our different counties and communities and making recommendations that try to represent a best fit for all those different communities at the state. Their recommendations from state especially come with an advisory to consult and work with the local health department and as we work to develop guidance that is tailored to meet the needs of Montgomery County. And our job is to focus more narrowly on what's happening in Montgomery County. Dr. Bridgers and his team take into consideration the CDC and the state guidance, but also looks at case rates, our vaccination rate, the behavior of the virus itself in general and in the county, where we are seeing surges, for example, and how the surges are taking place, how infectious the virus is, and how it may be spreading around in our community, and how effective we are in following the guidance and implementing safety measures that are necessary to protect all of us. Dr. Bridges is the person who writes and finalizes the guidance, but Dr. Bridges does not work alone. He's backed up by a team of epidemiologists and data analysts, physicians, public health professionals, the State Department of Health, and other health officers around the state and around the country. He is constantly in communication, and we're constantly talking to those folks to try to understand what is happening and share and compare information about how to proceed. The team digests available research and information from all corners of the world regarding coronavirus and its impact. The work of this team has resulted in Montgomery County having one of the highest vaccination rates in the county and some of the lowest case rates in the state. The guidance and the mandates from the Board of Health have not always been easy to follow, but you and me and others have followed it, and it has helped keep us safe. Omicron represented a new threat to us, but it also taught us some lessons. It taught us that a virus can spread faster than we thought it was possible. It has spread around the world in a matter of weeks, as you've all seen. It has taught us that vaccines work, but boosters help even more. The vaccine can protect us from serious illness, but that vaccinated people can still catch COVID. This is something I know from personal experience. It also has taught us that people who are vaccinated and boosted can transmit the virus. Omicron has made it necessary for us to be more cautious than we have in previous months. It's pushed us into higher levels of isolation and quarantine, higher levels of hospitalization. We are painfully becoming aware of higher levels of death in some cases. The research is still telling us that children, while susceptible to Omicron, don't have quite the level of severity, as far as we know at this point, that adults and seniors may face. That's the good news, and hopefully it means that our children will not be as badly impacted as others may be. The bad news is that children can spread it to others. They can spread it to other children, they can spread it to teachers, they can spread it to brothers and sisters, their parents, grandparents, and others in the community who might be more severely impacted. And that is the avenue of infection that we have to be careful about in this moment. We're trying to deny this virus opportunities to spread and to infect others. The overall job of public health and health and human services is to keep us safe and protected as best we can, and balance with the need for all of us to have normal lives, to be able to go to work, to be able to have our children in settings where they can be educated and where they can socialize and learn with other children. And for childcare, it's particularly important because this is developmentally one of the most important times in a child's life. So we want to make sure that childcare is available and as safe as possible. The guidance may differ from state and from the CDC at some level, and may seem more cautious and limiting. But ask you to bear in mind that this guidance, like all the guidance over the past 2 years, is time limited and will change as conditions change. We are watching Omicron and seeing what we hope is the tail end of this most recent surge of infections. And as those numbers go down and the situation changes, Dr. Bridgers will update the guidance to reflect those changes in conditions. The team that's with me tonight, you'll hear details about the guidance, and we'll work to answer those questions that you have for us, and any additional questions that we have time to answer. As you listen to them talk this evening, it's important to remember that this is guidance. It is not a mandate. It's the best guidance for how you as a child care provider and a business operator can keep you, your staff, and the children you serve and their families safe. And each of you has to make decisions that work for you and for your business as you go forward in implementing that guidance or following that guidance. So I'm going to stop there and turn it back over to you, Jennifer, and hopefully we will looking forward to having a great conversation this evening.
So tonight's conversation will be a series of question and answers that I'll moderate with our panelists. I want to remind everyone that many of the questions that were pre-submitted are what helped design this agenda. You can continue to write questions through the question and answer box, and we will try to best answer them throughout the evening, and we've a lot of time towards the end for question and answers as well. So I'd like to start with you, Dr. Bridgers. Before we get into the actual guidance, can you briefly share with us how our county is faring at this time with the Omicron virus, specifically as it relates to young children?
Sure. Thank you, Ms. Arnaz. And let me go back and thank Dr. Kroll for his walkthrough of where we are. We continue from a public health perspective to look at the best practice and even better practices to keep our county safe throughout all age groups. So just looking at some of the data that we have, our numbers are trending down back on January, and even going back to December, our case counts per 100,000 was very high. We had high community level transmission. On January 6th, we had 1,751 cases per 100,000. On January 9th, our case count continued to climb to 2,137 cases per 100,000. January 14th, it was still high at 1,861 cases per 100,000. And then as of the 25th, our case count is starting to decrease. That's an indication of all our community work and our great citizens and the resilience in getting vaccinated and continuing to get our boosters. However, there is a population, our under 5-year-olds, who are not vaccinated, and they are at the greatest risk. And we want to make sure those under 5-year-olds are protected. We've seen outbreaks consisting of more than 3 cases that was recently updated in December in our child care settings, where we know it may have a greater impact, not only on the children who attend those child care facilities, but those providers, those parents as well. And so we continue to look at better practices that will keep our community safe. As Dr. Kroll indicated, these recommendations and the guidance are in the interim. We've seen CDC change their guidance over the past couple of weeks to reflect the community needs, and we will continue to do that, as well as you will hear tonight. But just in looking at some of the numbers for our child care community, in November, we had 227 cases in our childhood or amongst our childhood providers. In December, we had 355 cases. And then just this month in January, we had 303 cases. So we know cases are occurring in our child care settings. And keep in mind that our children under age 5 are at the greatest risk. Similarly, as we did in our initial vaccination strategy, where we protected our 65 plus seniors, we made a concerted effort to keep them safe, get them vaccinated, and make sure that they are at the lowest risk. We continue this practice throughout our vaccination strategy, and we're now focused on keeping our under 5-year-old population safe. Not only those who attend child care settings, but also their parents and providers as well. So that's the current state of where we are with the data. Our case count continues to go down, and we will continue to look at the data, outbreak data, and where those cases I identified in the community, and will make the necessary changes to these interim guidance as appropriate.
Thank you. So there's also been some confusion within the child care community as decision tools have been released by the CDC, the state, and the county. As you can imagine, it's very hard to know which to rely on. Can you help our audience understand why our county government puts forth guidance and how they are used? Dr. Bridgers?
Would you repeat the question, please? I'm sorry.
Sure. That the guidance, there's many different decision tools that have been released. So can you help our audience understand why our county government has put forth guidance and how they are to be used?
So great question. So we take the guidance, as Dr. Kroll indicated, and just guidance and recommendations. And so we take that guidance and we look at our case count. We look at our primary indicators. We look at our hospitalization rates. We look at the impact on community level spread. And we take that guidance and we apply better practices that protect those individuals that it may apply to in the settings. In this case, our child care providers, and in some cases, our 5 and older settings. And so the guidance may change based on the community level settings. We also look at other data and dynamics from regional trends and where other cases that may have similarities to our community. But the guidance is set forth as recommendations to protect our community.
Thank you. Ms. Kinch, is this guidance the same as a mandate? What policies are childcare legally required to follow under county and state law?
For your question. No, the guidance is not a mandate. It is suggestive. It is there to help guide you in determining what to do in the event that there's that you have, less than an outbreak. A mandate is something that would require you to take particular action, and it has consequences for failure to abide. Currently, there are no mandates per se that apply to this particular group of people. However, that is only true in the event that there is no outbreak. In the event of an outbreak, the health officer is required under COMAR to take any action that is necessary in order to protect the public health. As Dr. Bridgers indicated, currently the definition of outbreak, it's defined as 3 or more positive cases. And in the event that happens, public health will get involved. At that point, they will provide recommendations, but in the event that those recommendations are not followed, the health officer can decide whether additional action is necessary, such as an order of isolation or quarantine. And again, that would be a mandate. If such an order were issued, that must be followed.
Understood. So the guidance as it stands now, can child care programs have the discretion to create more conservative policies if they so choose?
Yes, they can. They can decide that they want to be more conservative. They can really sort of decide one way or another whether they want to follow the current guidance or they want to set their own guidance. There is no requirement to follow the county's guidance, again, unless and until there is an outbreak, at which point our public health providers will get involved and there'll be specific instructions provided.
Thank you. Mr. O'Donnell, to understand the guidance, it's important that we understand the terms that are used. Many providers have been asking, what is the difference between isolation and quarantine? Can you help us understand the significance of these terms?
I can, and I would like to share a little visual aid here. They've been used a lot over the last 2 years, and quarantine describes individuals who need to stay away from others after they've had a close contact with somebody who has COVID-19. Individuals are quarantined because they may develop an infection from that close contact, and it can take a while before the infection is detectable. For isolation, that's a term we use to refer to people who are sick or who have tested positive. When they're sick or when they have COVID-19, even if they don't have symptoms, they need to isolate. Individuals are directed to isolate during the period when they're likely to be most infectious. And again, the CDC defines a close contact generally as anyone who is less than 6 feet away from you for a combined total of 15 minutes or more over a 24-hour period. And we do realize that definition of close contact is a little different in our school settings, as has been shared by our partners in MSDE and the Maryland Department of Health.
Another question that we have received is what exactly is it meant when they talk about, I'm sorry, you have another slide?
Oh, yeah, I'm sorry. I was just going to follow on a little bit about quarantine and isolation and why we use some of the guidance we do for quarantine and isolation versus just saying when someone's symptomatic or when they're not symptomatic, stay home. And that's because these periods, during these periods, people can be infectious before symptoms appear, after symptoms end, and even if they don't have symptoms. We're going to talk in a little bit when we talk about the guidance about why there's recommendations to do testing at a certain period of time. And that's again because it can take a number of days for an infection to grow to a level that's detectable. So close contacts who don't have symptoms are told to wait 5 or more days before they get tested. This is a recommendation from the CDC, and this is based on the number of days after their last close contact. That was all I wanted to cover with quarantine and isolation.
All right, thank you. Thank you. There's a lot to know about the difference between the two. I appreciate that. Thank you. So as I was saying, there was another question that we've received repeatedly as to what is meant exactly by well-fitting masks, especially when it comes to children under 5. How do we really assess what a well-fitting mask is?
Thank you. I know that's a great question as well. And it's something that we've been discussing because as many people are aware, the county's begun distributing masks as well as rapid tests out through the libraries, to childcare providers. So what we recommend is that individuals wear the most protective mask you can that fits well and that individual will wear consistently. We recommend that people pick masks with multiple layers that can keep their respiratory droplets in and others' respiratory droplets out. We recommend masks that completely cover the nose, mouth, and chin and fit snugly against the sides of the face and don't have gaps. So that's what we're looking for. But we know that children are different from a lot of people based on their size and their ability to wear masks. So there are masks that have been developed that fit children better, and a lot of these have come out through the cloth manufacturers. Again, we just want to remind folks that we understand the CDC and state and local health do not recommend putting masks on individuals who are younger than 2 years old. I'm sorry, I was just going to add on, as far as how to determine what is a good mask, a lot of people have talked about, and we've distributed our N95 and our KN95 masks. Those are medical grade masks that are used in healthcare. They're generally not made in smaller sizes. And in fact, some of our colleagues who work in healthcare have difficulty if they have a smaller face finding masks that fit them in that type. We have distributed them to adults and we've distributed them to our childcare providers or adults, but we're still trying to find these higher quality masks that can fit children. I know it's difficult. So there are some recommendations from CDC that we'd like to share, and that is that cloth mask with multiple layers, again, can make a good mask, especially if it does have that snug fit. Also that you can wear a disposable mask, such as sometimes they're called surgical or procedure masks, underneath a cloth mask, underneath a good fitting cloth mask. Again, those masks are often made for people who are bigger, but they are easier to find in child sizes. One of the recommendations that we can make is you can adjust the ear loops on those to try to make them fit more snugly. So these are all things that we share. They're on the CDC website and can help individuals find a mask that fits well and reduces the spread of droplets and other contagious material from one individual to another.
Very important. Thank you. So let's talk a little bit about the actual guidance itself. A significant distinction is made in the guidance between vaccinated persons 5 years and older and unvaccinated children 5 years and younger. Help us understand why that is.
Okay, well, I'll take you through just a condensed version of the guidance here. And one of the first things we want to talk about is a lot of this is based on the number of days that have occurred from either the onset of symptoms or a positive test, or in the case of quarantine, the last time you had close contact with an individual who has COVID. the full guidance is on our website, as people know, and we've shared that out with our child care partners. So the first thing is, one of the main differences is the quarantine guidance for persons who are fully vaccinated and boosted. And this is the same as our state's guidance and as the CDC guidance. If you're 5 and older and fully up to date on your vaccinations, or you're a person who tested positive and recovered from COVID-19 in the last 90 days, you would not need to quarantine at home. But for 10 days, you should follow some more protective measures, such as wearing a well-fitting mask whenever you're around other folks, even when you're outside the home, or when you're inside the home around others in your family, to prevent further spread. Avoid being around people who are at high risk for severe outcomes, and avoid travel if you can. And if at any point during these 10 days following your exposure, if you develop symptoms, you should get tested, stay home, and then follow the guidance for isolation. We also recommend for anyone in quarantine after 5 days to try to get a test to determine, following that exposure, to determine if they may be positive or negative. The second part of it is for those individuals who aren't fully vaccinated or have completed 2 vaccinations, and it's been more than 5 months since their Pfizer or Moderna, or more than 2 months since their J&J shot. They would be recommended to quarantine for at least 5 days after the last close contact. Now, after those 5 days, they're recommended again to get tested. And if that test comes back negative, they can then leave that at-home quarantine, again, still wearing a well-fitting mask, avoiding people who are high risk, and avoiding travel, all the way through their 10 days. Now, the state and the CDC guidance have mentioned that if you can't get a test, you could also return, because honestly, when their guidance came out, it was at a point where testing was very difficult to come by. We were at the height of the Omicron spread. And so they were trying to make this as accessible as possible to individuals. Within the county, we've gone to lengths to make rapid tests available and PCR testing available, including distributions out to our child care providers and distributions out through our libraries. So for under 5 years old, we're recommending that a reduced quarantine would only occur if a negative test is completed. Otherwise, it's the same guidance as over 5 years old. So the other scenario is if an individual has a positive COVID test or is symptomatic with COVID. So if they're 5 years and older, they've been recommended by the CDC, by our state partners, and by us to isolate at home for at least 5 days following the onset of symptoms or that positive test if they don't have symptoms. After 5 days, they're eligible to return to school or to work if they don't have symptoms, or their symptoms have resolved and they no longer have a fever for at least 24 hours without taking a fever-reducing medication. Just like isolation, though, they're still recommended to wear a mask at all times around others and not go out to places where they would need to be in close contact with others and have to reduce their mass. Again, they're also recommended to avoid travel and being around people who are at high risk. With our under 5-year-olds, this is where our major difference is with this recommendation. And it's that they isolate at home or a non-group setting for at least those full 10 days following the onset of symptoms or a positive test. If their symptoms have resolved and they have no fever for 24 hours, on day 11, they could return to those group settings such as childcare. And again, part of this is done because of the issue is that individuals can still be contagious even after 5 days. All of these precautions that have been recommended for the 5 and up are based on the ability to wear those masks consistently around others, and being around, in our county, a population that is highly vaccinated in those other settings that they're going back to. So we have less concern about the spread in those settings. So that is, in short, where the guidance is for that we have recommended here within our county.
Okay. So let's delve a little bit into the testing a bit more. We hear so many terms again that are unfamiliar to the layperson: molecular, PCR, antigen. Help us understand what type of test could be used. Is one better than the other?
Well, that is a good question. And I'm going to admit, there are days when I'm very confused about all the new tests, the rapid tests and other things that are available, but we try to stay on top of it. And we have a tremendous amount of information on our county website talking about all the different types of testing that's available. I'm going to share, in some cases, some web links, but our website has all of this information and links to all the other information. So who should test? First of all, any person who's symptomatic and or has been exposed to someone who has COVID-19 should get tested regardless of their vaccination status. The symptomatic individual should get tested as soon as possible. And asymptomatic individuals, as we've mentioned, with a known exposure should get tested after 5 days have passed since that date of exposure. Now, there's really three types of tests. There are two, however, that can detect an active COVID-19 infection. A PCR test, which is also sometimes called a molecular test, that's the one where specimens are sent to a lab and results usually come back 1 to 2 days later. During times of extreme testing, it can be more than 1 to 2 days, unfortunately. But with that, at our county sites, they have been very consistently over the last week, 1 to 2 days. The other type is antigen testing, sometimes called point of care, because it's a rapid testing, or at-home testing or take-home testing. And that's the ones that have been distributed out recently through our libraries and to our child care providers and in our schools. Those will give you a result in 15 minutes, and they can be completed at home without a clinician or a lab involved. There's some similarities with these, and there's a few differences, as that question was getting to. Both are very specific for COVID-19, which means if you have a positive result, it's very unlikely that that's not an accurate result. If you have a positive result on a rapid antigen test or a PCR test, you're positive and you don't need to retest, unless after consultation with your primary care physician, they say they think something else is happening. But in general, you don't need to retest for that. However, PCR tests and lab tests, they can be more sensitive to identifying COVID in people who don't have symptoms. Often people who don't have symptoms have a much lower level of viral activity in them, and we know the PCR tests are more sensitive. Individuals who do have symptoms, if they get a negative test with a rapid test, public health does recommend that they get a confirmatory PCR test to make sure that's not a false negative. False negatives do happen, not frequently, but more often with negatives than with positives. Now, where can you get these tests? At-home rapid tests, recently, our federal partners have shared that anyone can order 4 free tests. You go onto the website, you put your address in, and it states that about a week later, you will receive these 4 tests in the mail. Montgomery County has been distributing tests for 2.5 weeks now at 19 of our county libraries. Recently, we began handing out masks as well as those tests. We'll continue to do so as long as we have available tests. This is in addition to distributions we've done to our schools, both through Montgomery County Public Schools and our private schools, which began this week, as well as childcare, which began last week, and other populations who have difficulty getting out to sites, including those with mobility impairments, those with disabilities, or who are homebound. But also, these tests are available online. They're available at pharmacies and other stores. There's lots of places you can get rapid tests now. Many of them come 2 to a test. A few of them come 1 to a test. As far as PCR testing goes, our county website lists a large number of available sites that HHS or our partners in health initiatives or other groups that we verify do not charge for testing at all. We may collect insurance information, but there is never an out-of-pocket cost for testing at any of the sites listed on our county website. So we have a large number of those. It's available 7 days a week. As of the last week, there's plenty of walk-up space available. Lines are very short, very quick at any of these sites. There's also now a drive-through site at Montgomery College in Germantown. But we also know PCR testing is happening at pharmacies, urgent care, primary care, and other outpatient settings. There is generally between 60 to 80,000 PCR tests that occur in our county every week. So there's lots of places to go. And the state has done a great job of adding a searchable tool that you can type in where you are, set how far you're willing to go for a PCR test. So both of these are available fairly commonly throughout the county. And then finally, looking at, one second, please. So looking at how to report these tests and how to share them, which I'm sure is something, I may be jumping ahead of some of your questions, but it's something that we've heard a lot in the county. And PCR testing that go through the labs, all of the labs that do COVID testing are required by Maryland to submit all their COVID results into public health. That allows us to do contact tracing. That allows us to study the epidemiology of the spread of disease and figure out where to put resources in our county. And evidence of the testing is usually available from the lab or the provider who collected the specimen. With the rapid take-home tests, we have set up a portal that now the state is supporting that allows individuals to go on and enter a positive take-home test. The state is asked not to submit negative tests, but positive tests will go in, and that will support outreach through contact tracing. However, because you've done this at home, there is not a lab slip with information about your test. And public health, either at the state or local level, does not send out proof of testing. This will be up to our child care providers what type of evidence they want of a take-home test, whether it's a photo with something indicating the time when the test was done. It'll be up to our partners to determine what they want, as well as which types of tests they want to require, because there is, as we've just discussed, some differences between these.
Dr. Bridgers, talking about tests, I've heard a lot of the term test to stay protocols. Can you talk to us about, can programs implement a test to stay protocol for their child care business?
Yes, great question, Ms. Arnaz. So let me just back up. Thank you, Sean, for walking through all of that. But yes, the bottom line is yes. We've moved away from MSDE's, OCC's guidance back in October when we didn't have over 2 million test kits in the community. The county executive and government has gone through great lengths to procure these tests. And so now we have a vehicle that allows our child care providers and our parents to be able to test to return or test to stay. When we followed up with MSDE prior to even after the release of our guidance, we've already included that opportunity. And we asked our child care providers to submit their letter of approval through our letter of approval committee so that we can review, as we've done as our standard practice, to review those plans to test to stay. And we can offer additional guidance separate from this forum this evening. But we wanted to have that, again, that resource, that protective tool in the community now, because we understand from a family dynamic, from a provider dynamic, from a business dynamic, the utility of having a rapid test, which provides an indication of an individual's a viral load and or status. And so now we have that tool and resource available. And so we will move in that direction to allow a test to stay.
Thank you. And is that information found on our website?
Yes, and we will provide the information so that the audience can have it, and we will follow up with additional information as needed. But that is a new tool, and we've moved away from that from originally when licensed providers could not use an over-the-counter or rapid test for individuals, but now we are considering that. Again, the bottom line is to protect the community. We know that individuals who test positive are at greater risk, I should say, or individuals who can transmit the virus to the community. And so we want to make sure that we continue to look at those safeguards.
Wonderful. We will definitely send that out in our e-blast to our child care community and add that to our social media handles as well. Dr. Stoddard, so with all this talk about the guidance and really the evolution that it's gone through as we learn more about the virus and its variants, can you share with us, big question we get, will there be more changes to the guidance?
Yes, there absolutely will be more changes to the guidance, as I think Dr. Kroll and Dr. Bridges already alluded to. Obviously, we're on the downswing, we believe, of our Omicron surge, and there will be an opportunity for us to reevaluate over the coming weeks the guidance that's been offered. I think Dr. Bridges has previously described it as interim guidance made around the Omicron surge. And so I would anticipate that, for example, as you know, the county council as the Board of Health is considering the mask mandates, they'll be looking at data, and we'll be looking at the same data to make recommendations around the mask mandate. That the same kind of data that will be considered in that kind of decision will be what we're looking at for our childcare providers. Obviously, Dr. Bridges has already alluded to the case counts in an outbreak that occur in childcare settings. We'll monitor those, and as we continue to see a reduction as Omicron surge ends, that will be a time where we'll reevaluate within public health those recommendations.
Right. So for those who have asked about the metrics that are used, that the county uses to determine, those are exactly what we'll be looking at. Thank you. So also this week, the Board of Health extended the mask mandate through February 21st. Can you tell us what metrics will be used to lift the mask mandate? Yeah,
so there's three principal metrics that we've recommended they look at. And I want to talk a little bit about those. So those are cases per 100,000, the test positivity, so how many of the tests that are being run in the county are actually coming back positive, what percentage of those, and then the percentage of hospital beds occupied by COVID-19 related patients. As we previously talked about, as we have a more vaccinated population and we move towards a more vaccinated and immunized population, we are going to focus less on case count. So as case count, we're going to have a higher tolerance for cases, but also be focused on hospitalization as an increasingly important metric to consider. And so those are really the three measures. I'm sure there will be others as they look at the data. We have a lot of metrics on our website that will be considered. But I think the primary considerations that the Board of Health will be looking at are we seeing diminishing cases and positivity in the context of also reducing hospitalization?
Thank you. Ms. Townsend, so we've heard a lot about the guidance, and we've heard a lot about the definitions, the words, the terminology. Let's talk a little bit about what happens now when there is a suspected or confirmed case of COVID in a child care program. Who does the child care provider call?
Well, child care providers must make two calls. One call is to their licensing specialists and the other to the county's COVID call center. And that number is 240-777-2982.
It's on our website as well. So can you tell us a little bit, what can a provider expect when they make the call to the county's COVID call center? What information should they be prepared to share with the counselor or the intake counselor?
So one of our call center representatives will ask them some basic information. It's very important that they have a name of a primary contact that they can follow up with. They will ask them for their phone number as well as an email address. They will also ask them for the name of the facility and the facility's address, as well as the type of facility. They will take this information and forward it to our disease control team, who will then follow up with them. That's why it's really important to have the correct contact information.
Can you share with us how decisions are made with regarding closures of a classroom, a program, or in the case of a family childcare, the entire program?
Sure. So decisions about closing classrooms or centers are based upon the guidance. We do what's called tracing, and we identify what the quarantine needs are within a classroom. For example, if there's a classroom where there was an exposure and everyone in the classroom was present while the person who was identified as infectious or infected with COVID, and their close contacts, it's possible that that particular classroom may close because all of the other students in the classroom were exposed at the same time. So in those instances, we may recommend to close the classroom.
So yes, so each situation has its own unique criteria to make those determinations. So there really isn't a one cookie cutter answer to that. I appreciate that.
Sure.
Stoddard, I'd like to talk a little bit about access to vaccines and children under 5. I understand that both Pfizer and the BioNTech are awaiting approval from the FDA for a vaccine for children under 5. Can you share what the county, how the county is preparing for this?
I'll actually probably ask Dr. Bridges to take on this a little bit, but I think Dr. Fauci was commented over the weekend as saying, they're expecting the FDA to review and likely approve the request for 2 to 4-year-olds to be vaccinated. It will likely be a 3-dose regimen as opposed to a 2-dose regimen. The 2 doses that were shown in the trial were not fully effective in getting the immune response that is necessary for COVID-19, but a 3rd dose was shown to be more effective. And so it's likely to be approved as a 3-dose regimen sometime over the next month. And I'll turn it over to Dr. Bridges to talk about the preparedness that public health has been making to be ready to vaccinate this population.
Sure. Thank you, Dr. Stoddard. Just this week, we responded to the Maryland Department of Health survey for local health departments to identify and or discuss their 2 to 4-year-old pediatric vaccination strategy. We've done that in the past, and we've typically been 2 or 3 months ahead of any vaccine planning. Our 2 to 4-year-old vaccine planning will be similar to our 5 to 11-year-old vaccine plannings. We know that our providers, our pediatric providers, will be instrumental along with our pharmacies and our other community partners who've been very instrumental in our vaccine rollouts throughout this past year and a half. And so we will continue to use our hub and spoke model. And we will be reaching out to our larger providers to assess their capabilities to support vaccine clinics. We will also continue to use our racial and equity framework so that we can ensure that those families and those communities will have access to any vaccines that are approved by FDA and by CDC's ACIP. And so we're working on that plan now. We will continue to refine the plan based on community input. We will have ongoing conversations as we get closer or we are aware of a approval date. And so we will disseminate additional information, and we'll request additional input to say from the community to ensure that we are ensuring the best practice, again, to protect and keep our community safe.
Thank you. Dr. Stoddard, last week, the county distributed, as you've heard, 25,000 at-home COVID tests to child care programs to give to staff, as well as enrolled children. In addition, over 32,000 KN95 masks were also distributed to child care staff. This was quite the accomplishment. Can child care programs expect a repeat of this?
So actually, I have new totals. It looks like we're up to 31,764 kits, which is great. 806 child care centers did receive kits and masks last week. We received new allocations both yesterday and today, and from those, there are additional allocations for child care centers, nonprofits who serve children, as well as private schools and other organizations. So the short answer is yes, you can expect to see more kits coming through. As the county receives more kits, we'll be making allocations to child care centers to help sustain the efforts through the Omicron surge.
Wonderful, wonderful. So I'm sure we'll coordinate those efforts with our child care support services to distribute the forms, the signups and such, so we can get those out. I appreciate that. So now what I'd like to do is answer some of the questions in our Q&A. So give me a second as I scroll up. And I will be calling on various panelists to respond. So there were quite a few questions about, is guidance recommended or should it be considered mandatory? So that question there really comes down to, are we following it as a guide or are we following it as a mandate? Who would like to take that? Dr. Bridges?
Sure. So the guidance that we issue is the guidance is our recommendations, I should say, based on our review and interpretation of CDC's guidance and MSDE and MDH's guidance. In some instances, they may be more protective. So when we talk about risk for under age 5, the guidance and the recommendations that we crafted are not so much to protect those who are under 5, but to mitigate spread as well. So we know that with Omicron, we saw increased transmissibility with this variant. And so not only to protect those under 5, but to also protect those providers and to mitigate further spread. In some instances, they may not be as stringent. And so those recommendations and guidance are set forth, as well as Dr. Kroll and Mr. O'Donnell and Ms. Kinch and all the panelists. Dr. Stoddard indicated that these are interim guidance, and we look at the metrics. We consult our pediatric public health advisors, our infectious disease doctors, our epidemiologists, and we look at the best practice and craft the guidance based on where we see our data points and the impact that will have to mitigate and suppress any community level spread.
Can I make one additional comment here? I know there's a lot of consternation about the fact that the isolation timeline is a little bit longer from the state guidance at the local level. But I think a key feature that I think you have to understand is I don't think there's a different or a hyper level of concern that young kids are going to get increasing, super sick and hospitalized and die. I think there's a twofold concern here. Obviously, it's a fully unvaccinated population at this point. It's a population that has difficulty. We all know, I'm a parent. I've had 2 to 4-year-olds at various points, and I know that wearing a face mask is challenging for this population. And so, the key thing here is balancing having people get back into the facility for working families as much as possible, with the fact that if you have unchecked COVID-19 spread in your facility, you will see more cases and more quarantines. And so there's a very delicate balance that we're attempting to strike here by having a little bit more conservative view of isolations, where we know on average 31% of people are likely to still be infectious after day 5. Those 31% of people who those children or staff members returning to the facility too soon could cause further spread within the facility. And so the quarantine timeline being 5 days is something we wanted to make, because obviously that affects a larger number of people, and many people who are quarantined do not come back positive. But at the end of the day, those people who have tested positive, if they come back too early, will pose a risk of further spread within the facility, which again, isn't just about our kids going to get sick and die. That's not what we're saying. It's largely to prevent the spread within the facility so that you can safely operate without having to close down, without having more quarantines, et cetera, et cetera. So you don't want it to snowball. You want to have kids in the facility, but you also don't want it to snowball out of control.
Sure. And just to add to Dr. Stoddard's comment, through a more conservative practice, especially for this population, this under 5 age population, in our conversation and discussion with our hospital providers last week, we don't have the level of pediatric cases that we're seeing presenting in our emergency departments or urgent care centers now, as opposed to the Children's National Medical Center that had a little over 60 cases last week, I believe it was shared with us. And half of those cases were related to the coronavirus. They didn't say whether or not it was one particular variant or strain, but we know that Omicron is the predominant strain in the nation now. And so protecting those who are unvaccinated are one of our primary measures.
So there's many things that we've heard tonight that helps with our practices and policies. And as a child care program owner, to really consider everything, all the information that is being given to them to create policies that help them maintain a safe environment for the young children. We've talked about well-fitting masks, the reality in childcare. Children take off their masks at nap time and mealtime. It may not be worn well-fitting, as the description has been said. And so, using those guidance to decide what policies to create are helpful. And this guidance from the county does just that, provides you with the tools necessary. Let me go further down here. Give me 1 second. My scroll went up. So we talked a little bit about metrics already, the current guidance will change. We've had a couple of questions about whether the guidance will change, and it will change based on the information we have at the time, and as well as the metrics that we're using to determine if case count go up or down. Let's see. I feel like we've gone over many of these questions already. There was a question about outbreak. To clarify, an outbreak is considered 3 or more cases in a classroom or a facility. Dr. Bridgers or Kimberly Townsend?
Kimberly would answer that best.
So that would be 3 or more confirmed cases in a classroom. For a facility, we look at it after 5.
All right, so that answers that. I think I've gotten through most of these. Oh, are there any guidance for those who travel out of state? Has Maryland instituted any policies on that? Do they need to test before entering back to the workforce or childcare? Dr. Bridgers?
Not that I'm aware of.
Okay.
No, it's probably not necessary obviously COVID is here. There's not a place where you're going to go that's going to necessarily be substantially higher risk. Now, obviously with travel, if you're into, traveling through an airport, for example, there's just, more people in a close proximity to one another. So you don't need to quarantine or anything like that, but just monitor your symptoms closely and, test if you feel or your children feel or your staff feel any concern about a potential exposure and or illness.
Ms. Townsend, here's some clarifying questions. Are the isolation guidelines from the date of positive test or the first date of symptoms?
So isolation guidelines, if you have a positive test, it's starting at the test. If you're having symptoms, it's by the symptoms.
So it depends which one you're going with. Okay. And another clarifying question. Are children under 5 who have had COVID in the past 90 days required to quarantine if exposed at school?
So that's a great question. We just had a follow-up this afternoon. Go ahead, Mr. O'Donnell. You can respond, but based on a conversation with the Maryland Department of Health, those individuals are still considered exposed and should quarantine for 5 days, if I'm not mistaken. Correct, Mr. O'Donnell, based on our conversation?
That's our understanding right now, but that's a really good question, and we'll certainly follow up with this and try to clarify this within our frequently asked questions on our webpage to make that clear for other folks.
Okay. All right. There's a question again about the test to stay program. If the guidance are recommendations and not a mandate, why is a letter of approval required to do test to stay? Dr. Bridgers?
Sure, I'll start. So as part of that letter of approval process, it's more so to ensure that those public health safeguards and measures are in place. So we will examine the program. We will ensure that providers have the adequate resources, the number of tests, to look at the frequency. And so it's more so of a review. And then we provide feedback. And then once we've, the approval committee has approved and accepted the plan, we'd like to have it as a measure or indicator of what that provider is actually going to do and to offer recommendations if necessary.
And there are a few questions in here. I just want to let the audience know regarding MSDE and their role, and then our heart health department role. To be clear, MSD is a licensing body that oversees childcare, but when it comes to any type of outbreak, the local jurisdiction is the one that determines what the next steps are for that program. So I'm not going to answer those questions on behalf of MSDE. We can send those forward and have them answer them. Okay, I think many of these questions are repetitive. So the big key, I think, unvaccinated under 5, exposed, can take, must isolate for 5 days, and then they can test on day 5 to see if it is negative or positive. If it's negative and they have no symptoms, they can return to childcare.
If they are exposed, they should quarantine. They should isolate if they test positive. So if they quarantine for 5 days, on the 5th day, they can return on the 6th day, or they can take it in the morning and return to the provision. So isolation, 10 days, quarantine, 5 days for an exposure.
Great. See, even after 2 years, I'm still getting them confused. Thank you. Okay. So I'd like to end this evening with Dr. Stoddard, some final thoughts and anything else you'd like to add to this conversation.
Yeah, I mean, we certainly, you know, I know that there's been several comments about some of the clarity of the January 26th, and we're gonna, obviously, in terms of clarifying, we'll take a look back at some of that feedback, and you know, if there's ways to express things that can make it more clear, we'll certainly always be looking for those. And so, obviously, you know, if you have additional questions after the session or things come up and you want to call and just reach out to the health department and get some clarity on how to operate, I certainly think that is, you know, certainly think that's totally appropriate. But at the end of the day, obviously, we're trying to provide you the best guidance that we can with regard to how we think you can most safely operate your facility. As we've noted routinely throughout this session, it is guidance, not a mandate to operate a particular way. You need to decide what operates best for your facility. That may mean you choose to be more strict in certain circumstances. That may mean that you're going to, you know, follow a different set of guidance, like the Maryland State Department guidance for how you're going to generally operate. Obviously, once or if there's an outbreak of 3 or more cases in a classroom, we will, at the local health level, be involved and provide you with direction, not guidelines for how to manage that outbreak. And so, just understanding how things will go, and which I want everyone to be clear. Obviously, as we've already alluded to, we will be looking at these guidelines repeatedly over the next several days and weeks. And as the conditions on the ground change with Omicron or additional facts become available, like 2 to 4-year-old vaccinations, obviously that will heavily influence how the recommendations are made with regard to childcare facilities for under 5.
Thank you. So I want to thank our panelists and our audience for sharing this time together. We hope you have found it helpful. I want to remind everyone to continue following the Child Care Support Services on social media. Please sign up for our e-blast to stay connected with the latest information. This is the main conduit for us to send information to our child care providers. If at any time there are questions, please feel free to call our child care health nurse at 240-777-GROW. You can also send us an email at ccss@montgomerycountymd.gov. Our child care health nurse is available to help you interpret, and she does work with HHS, so she can help be the liaison if you're having some challenges. We will post this recording tomorrow on our various social media handles in the county and our website. So again, thank you to our panelists, thank you to our audience, and I wish everyone a very good evening. Good night.
So it's really changed our reach to something national, very unintentionally, but we're excited about it. But also in the Washington, D.C. area, which is where our roots are, and into Northern Virginia and Montgomery County, Prince George's County. You know, it has given us just the chance to get the word out to more people, and we're busier than ever now.
James, as you get the word out, do you notice that there are also benefits such as maybe the psychological and social benefits?
Absolutely. You know, I think that is where the calming influence of an animal can be so powerful. And many of our visits are calming.